The Kanski lecture series, and today we are going this is the eyelid part 10, and we are going to start about the ectropion. So there are different type of ectropion. What is, firstly we need to define what is ectropion. Ectropion is basically the eversion of the eyelids. Mean, if the eyelids are resting in a normal position, they are everted, and that can be the marginal or a complete lid ectropion. So there are different types of ectropion. It is involutional ectropion, which is due to age related. It can be due to cicatricial ectropion, which is due to the scarring. It can be paralytic ectropion, which is due to some nerve related issues, and mechanical ectropion due to the mass that is causing the eversion of the eyelid. So we will discuss each in detail. So one of the very important cause of ectropion is involutional ectropion. Involutional ectropion is basically the age related changes in the ectropion causing the ectropion. Introduction. Involutional age related ectropion affects the lower lid of elderly individual. It causes epiphora, tear flow, and may exacerbate ocular surface disease. The red appearance of the exposed conjunctiva is cosmetically poor. In long standing cases, the tarsal conjunctiva may become chronically inflamed, thickened, and keratinized. Etiological factors include so basically you can see this is the long standing involutional ectropion, and there is an eversion of the lid, and due to the exposure of the tarsal plate in the conjunctiva, it become keratinized and thickened, and in the case of the long standing ectropion. So one of the important thing is about to discuss about the causes of the involutional ectropion and entropion. You must know about the causes of the involutional ectropion and entropion. So for in the ectropion, it is the horizontal lid laxity, lateral canthal tendon laxity, and medial canthal tendon laxity. So there are certain kinds of test procedures, clinical tests that you can do to see about such conditions, what is causing the ectropion. So horizontal lid laxity means that the skin or the lid is lax. It is loose or slightly lax. Lateral canthal tendon laxity means the lateral side of the canthal is lax, and the medial canthal tendon laxity being the medial side of the eyelid is laxed. Horizontal lid laxity can be demonstrated by pulling the central part of the lid 8 mm or more from the glove, with the failure to snap back to its normal position on release without the patient first blinking. So there are test procedure known as snap back procedure, and one other is a snapback test and a pinch test that is done to evaluate the horizontal lid laxity. So what you do is you place the finger in the lower eyelid, and when you place the lid and you pull the lid almost 8 from the eyeball. So when you release that finger, it will not go back to the eyeball, so it means that the horizontal lid is laxed. Lateral canthal tendon laxity, characterized by the rounded appearance of the lateral canthals and the ability to pull the lower lid medially more than 2 mm. So in the case of the lateral canthus, so for example this is an eyelids and this is the lateral canthus. So lateral canthus will be round, and when you push the lid to the medial side, it will go more than 2 mm from its normal position. So it means that a lateral canthal tendon laxity is also present. Medial canthal tendon laxity demonstrated by pulling the lower lid laterally and observing the position of the inferior punctum. If the lid is normal, the punctum should not displace more than 1 to 2 mm. If the laxity is mild, the punctum reaches the limbus, and if severe, it reaches the pupil. So for example, this is the lids, and this is an eyeball, and what you do is you stretch the lateral medial side to the lateral area. So what happen is that it usually do not move more than 1 to, so you when you see the inferior punctum, it should not move more than 1 to 2 mm. But if move up to limbus, it means that a mild laxity is present. If it moves till the pupil, it means the severe laxity is present. Treatment. The approach to repair depend on the apparent causation and the predominant location of the ectropion. Generalized ectropion, medial ectropion, medial canthal tendon laxity, and punctal ectropion. So these are very important causes of the ectropion. One should know about the causes of the ectropion to its treatment. So generalized ectropion mean all of the lid is involved, means all of the lid is having the eversion. So in this case we will treat it generally. Generalized ectropion is treated with the repair of the horizontal lid laxity. This is achieved with the lateral tarsal strip procedure, in which the lower canthal tendon is tightened by shortening and reattachment to the orbital rim. This is particularly helpful if the lateral canthus is rounded and lax, which with associated tear overflow. Excision of the tarsoconjunctival pentagon is an alternative that can be um, placed in to excise an area of a misdirected lashes or keratinized conjunctiva. So how we treat it with the generalized ectropion is with the tarsal strip procedure. So we will see the figure to discuss the procedure. So this is the tarsal strip procedure. A is doing a lateral canthotomy. So what are you doing is basically you are excising the lateral side of the uh, uh, lateral canthal area, and after excising the lateral canthal area, B is doing the cantholysis. The lower limb of the lateral canthal tendon angle is cut away from the inferior orbital rim. So you know that the lateral canthal has superior and lower limb. So we excise the lower limb of the lateral canthal tendon from the inferior orbital rim. C is showing the interior and the posterior lamellae are divided and a strip of the tendon or lateral tarsal plate dissected out. So in this case you can see C figure is showing that we have separated the lateral side of the lid into the interior and the posterior lamellae, and we dissect the lateral the tarsal strip of the posterior lamellae. The strip is shortened and then reattached to the inner aspect of the orbital rim periosteum with the 4-0 absorbable suture. Excess lid margin is trimmed. Excision canthotomy is closed. So what you do is basically after you dissect, you expose the lateral tarsal strip, you excise the strip and shorten it, and the rest of the lateral tarsal strip is then attached to the inferior orbital rim with the absorbable suture, and then you also can excise the excessive skin, and then you suture the skin. So this is the lateral tarsal strip procedure. After that is another procedure for the generalized ectropion is you treat it with the lid shortening. It is especially helpful when there is a lot of keratinized conjunctiva. So what do you do is you basically do the pentagon excision in the eyelid, full thickness pentagon excision. After that you suture the incision. You suture the incision. So this is how we treat the generalized ectropion. Medial ectropion, if mild, may be treated with a medial conjunctival diamond excision, medial spindle procedure. It is often combined with the tarsal strip or lateral canthal sling or pentagon excision as significant horizontal lid laxity frequently coexist. So whenever there is a medial ectropion, so what is the medial ectropion? Medial ectropion is basically ectropion in which the lid is usually normal, but the medial side of the lid is usually everted. So in that case, what you do is the medial conjunctival diamond excision, which is also known as a medial spindle procedure. You make the diamond shaped cut in the conjunctiva for the laxity, and then when you excise the conjunctiva, you suture the remaining part of the conjunctiva. And sometimes it is also done with the lateral tarsal strip procedure, because the horizontal lid laxity often coexist. Medial tendon laxity, if marked, requires stabilization prior to the horizontal shortening to avoid excessive dragging of the punctum laterally. Punctal ectropion without more extensive lid involvement is considered in chapter 3. So sometimes that there is only the punctal eversion. So punctal eversion, the treatment of this is discussed in chapter 3 of the lacrimal drainage system. Next is a cicatricial ectropion. So there are cicatricial ectropion basically means the scarring which is causing the ectropion. So whenever there is a skin scarring, it causes the eversion of the lid, because the tightness and shortening of that interior lamella causing the eversion of the eyelid. So what you do is basically you cut the scar tissue, and you can replace it with the uh, flap, or you can also replace it with the graft. Cicatricial ectropion is caused by the scarring or contracture of the skin and underlying tissue, which pulls the eyelid away from the globe. If the skin is pushed up over the orbital margin with the finger, the ectropion will be relieved. Opening the mouth tend to accentuate the aversion. Depending on the cause, both lids may be involved, and the defect may be local. For example, trauma or journal burn, dermatitis, ichthyosis. So it can be due to trauma or any other journal thing which causes the scarring of the skin. Mild localized cases are treated by excision of the offending scar tissue combined with a procedure that lengthens vertical skin deficiency, such as Z-plasty. Severe generalized cases require transposition, flap, or free skin graft. Source of the skin include upper lids, posterior auricle, preauricular, and the supraclavicular area. So these are very important to know where we take graft for the replacement of the cicatricial ectropion. So paralytic ectropion, the facial nerve palsy is very much associated with the ectropion. And why is that so? Because the orbital orbicularis muscle is lax or loose, which is causing the eversion of the lid. Introduction. Paralytic ectropion is caused by the ipsilateral facial nerve palsy and is associated with the retraction of the upper and the lower lids and brotosis. So brotosis mean that due to the excessive skin in the eyebrows, it causing the ptosis. The later may mimic narrowing of the palpebral aperture. Complications include exposure keratopathy due to lack of thalamus, and watering caused by the malposition of the inferior lacrimal punctum, failure of the lacrimal pump mechanism, and increase in the tear production resulting from the corneal exposure. So basically in this topic he is more likely discussing about the facial nerve palsy. So what does it happens in the facial nerve palsy? Basically the facial nerve is the seventh nerve which supplies the orbicularis muscle of the eye, and it is a very important muscle, especially in a cases of the closing of the eye, and especially when you want to drain the tears, because it is for the lacrimal pump. It acts as a lacrimal pump as well when you blink. So when the orbicularis muscle weakened, the lacrimal pumps failed, and there will be the increased tear production can be caused by the corneal exposure. Why corneal exposure is because the patient is unable to close his eyes properly in a case of the seventh cranial nerve palsy. So lack of thalmos means the patient is unable to close the eye, and there will be the increased tear production. So what is the treatment of this condition? Basically the treatment is that there can be the temporary measures that you can do or permanent. Why we do the temporary measures? Because there is a chances of improvement in the case of the facial nerve paralysis. So we temporarily do things to relieve the symptoms. Temporary measures may be instituted to protect the cornea in anticipation of the spontaneous recovery of the facial function. Lubrication with high viscosity tear substitute during day with installation of the ointment and taping shut of the lids during sleep are usually adequate in mild cases. So you know that the eyelids are unable to close, so you give lots of lubricant during the day and ointment in the night, and shut the lids by taping the eyelids in night. Botulism toxin injection into the levator to induce temporary ptosis. So Botox injection is also used to temporary inducing the ptosis. The ptosis will protect the eye from the corneal exposure. Temporary torsography may be necessary, particularly in patients with poor Bell's phenomena where the cornea remains exposed. When the patient attempts to blink, the lateral aspect of the upper and lower lids are sutured together. So there are sometimes when the facial nerve is permanently damaged, for example in case of the operation, during the parotid surgery or any other kind, that there is a permanent trauma to the facial nerve, we can do the permanent treatment as well. Permanent treatment should be considered when there is an irreversible damage to the facial nerve which may occur following removal of an acoustic neuroma, or when no further improvement has occurred for 6 to 12 months in a Bell's palsy. Medial canthoplasty may be performed if the medial canthal tendon is intact. The eyelids are sutured together medial to the lacrimal punctum so that the puncta become inverted and the fissure between the inner canthus and the puncta is shortened. So what do we do in the cases of the medial canthoplasty? So this is the showing the permanent treatment of the paralytic entropion. It is showing the medial canthoplasty. B is showing the lateral canthal sling. Refashioned canthal tendon from the lower lid is passed through a buttonhole in the tendon from the upper lid. I will explain in this other. Basically in this case what we do is basically medial to the, so this is a puncta, and medial to the puncta we suture the upper and the lower eyelid so that the distance between the inner canthus and puncta is shortened and the patient is able to close his eye. Lateral canthal sling or tarsal strip may be used to correct residual actropion, actropion and raises the lateral canthus. So in case of the lateral canthal sling is basically the that a canthal tendon has a two lateral canthus has two tendons. So what is, we separate the lower canthal tendon and we make the buttonhole in the tendon in the upper lid, and when we put that tendon into that hole of the upper lid, and this is called the lateral canthal sling procedure. Upper eyelid lowering by the levator disinsertion. So you can also disinsert the levator muscle. Why? Because it will causes the ptosis, it will induce the ptosis. In a patient with lack of thalmos, either gold or platinum weights can be implanted into the upper lid. The platinum weights are preferred because they are less bulky than gold weights, provide a better eyelid contour, and are less likely to need long-term revisional surgery. So you can put the weights on the upper lid as well. What will it cause? It will induce some kind of ptosis in the patient with the weights. A small lateral torsorrhaphy is usually cosmetically acceptable. So Mechanical ectropion. Mechanical ectropion is caused by the tumor or on or near the lid margin that mechanically evert the lid. Treatment involves the removal of the cause if possible and correction of the significant horizontal lid laxity. So in case of mechanical ectropion, you just remove the cause. So that's it for the eyelid part 10. See you in the next lecture.